introduce Robin real quick. For those of you who have not been on one of our webinars, this is Robin Carlson from Stratus Health. She is our go-to person. Anytime we have questions about MBQuip, the data, the specifications, she's our go-to person. She is also the person that leads the Abstracting for Accuracy program, which is awesome. So if you've not participated and it's something you're thinking about, Robin is your go-to for that. So Robin, I'll turn it over to you.
So hi everyone, thanks Laura for inviting me today. As Laura said, I work with the Rural Quality Improvement Technical Assistance Team, and we came about because of the fact that critical access hospitals weren't really getting much support from CMS to do abstraction anymore. So what our team does is assist the LORAs across the country with helping you guys with abstraction and reporting and quality improvement around the MBQuip measures. And my specific role is helping with the abstraction and reporting. And what we want to talk about today is the EDTC measure. And so what I want to do is I want to start from the very beginning and show you where to find the manual in case you haven't found it before, and then go over the different areas in the manual. And I found that really the instructions for how to do this haven't changed in quite some time, but a lot of people maybe didn't get any education around do this. You know, when they had to start doing this, they might have just been told one day this is your job, or you know, here's the online tool, and not really discussing much about the population and really what kind of documentation we're looking for. So that's what I would like to talk about, because I've really found some people are maybe missing some of the population that should be included. And then maybe picking up some documentation and answering the data element questions as yes when that's really not what we're looking for. So I do want this to be real informal. I don't know, Laura, if people are muted or how they can ask questions, but at any time you can stop me for questions.
Okay, so just to touch on that, everyone has the ability to mute and unmute yourself. If you're not able to, shoot me a message and I can either ask your question or go in and manually unmute you.
Okay, because again, I don't want to go on if somebody really has a question, and you know, you probably hear this a lot on webinars, but you know, there's not a stupid question, because if you have it, there's probably someone else that has it as well. So that's what I want to do. And let me just say, maybe you've heard that the EDTC measures, the data elements will be changing starting in 2020. And that's true, starting with 2020 encounters. There are some changes, but the big changes are just going to be some of the data elements will be missing. There's a lot less of them, but the main data elements that really pertain to that visit, why that person has come to the ED, are still the same, as is the population and the documentation. So none of that is changing. So the stuff that we're focusing on today is going to be continuing with the new manual and the new measures. And we'll be sending out information probably within the next month or so about how to sign up for training on the new manual. So there'll be plenty of training in enough time for before when you have to start collecting for the 2020. So for people who maybe have never figured out or don't know where the manual is, this is the easiest way to find it. This is the Stratus Health website, and the reason it's on the Stratus Health website is like that's who I work for. I mean, I'm doing this job because it's the Rural Quality Improvement Technical Assistance Team. That's the agreement we have with FORHP. But I work for Stratus Health, and we are the one, along with the University of Minnesota Rural Research Center, who developed the EDTC manual. So that's why this information is here on our site. So if you go to the, click on www.stratushealth.org, this is our main page. And the easiest way to find the manual is in the search, type EDTC. And Laura or anybody let me know if you're not seeing things or whatever. But okay, you get the search results, we want the data specifications manual. Okay. If you were wondering where the tool is, if you use the EDTC tool, you can go to this, the resource page, this resource page up here, and that's got the tool as well as the manual. That's the main page with all of the information on it. But if you just want to know the manual, here it is right here. Okay, so we've got our manual, and it does say this is the most current version, June 2017. Now, I really wasn't aware of this till we did a pilot about a couple months ago now on the new EDTC measures. And we had some of the hospitals go through the manual, give us some suggestions if they had any, you know, things that weren't clear to them, that kind of stuff. And one thing I found out in the course of that is someone had a manual that said June 2013. So if by chance you have any, I don't really know how that is even out there anymore, but if you have an old manual, please don't use that. Use the one that's dated June 2017. This is the most current manual. And hopefully everybody is aware that there's a manual. So again, but this is where you find it if you've never seen it before. Table of contents, I don't need to read you the manual. This beginning is talking about the different submeasures. This is where all of the data elements fit underneath these submeasures. And I'm going to skip that, but if anybody has any questions, just let me know. What I want to say is, we get a lot of feedback around these measures, and there are a lot of people who don't think that they're relevant. And I don't understand that personally. I want to tell you these are not going away. I mean, CMS, you'll notice how CMS is removing some of the measures, and it kind of seems like every year we've kind of got less measures. This is not a CMS measure. This is a measure that came about because of the feeling that this was an important part for critical access hospitals, that you see a lot of people in your ED and then, you know, transfer them or discharge out. And we need to make sure that that information of what happens in that ED encounter is going to the facility where that patient is going to. And I know a lot of people think, okay, you know, acute care hospitals, I get that. We're transferring to acute care hospital. That's not where a lot of the issues seem to arise. It's more with other healthcare facilities. And people have a big one. The biggest issue tends to be around the nursing homes. And if you just think about it, okay, maybe you've got a person who resides in a nursing home, but they're sent to the ED for whatever reason. Then they go back to the nursing home. That nursing home needs that information on what happened in that ED. Maybe it was a med change, you know, maybe, you know, chest x-ray, a new diagnosis or whatever. That information needs to go there. So I just think when someone explains it to me like that, or when I hear it like that, I think, how could you think that these aren't relevant? I don't know. But so, you know, if anybody has any thoughts about that, they can always let me know on that too. But these aren't going away. So these are the measures. This is the big area right here where I think people have the most issues. It's the population and sampling. So when we use those terms, what we mean here, these are the records that you have to do, okay? These are the people, the population are the people that are seen in your ED and are transferred or discharged to these following facilities. Now again, what I have learned is some people, a difference of terminology. Some people said, well, we only do transfers, and if we discharge them, we don't do them. No, that's not correct, okay? Whichever phrase you use, if they're transferred, if they're discharged, that phrase isn't important. The importance is, where are they going? From that ED, where are they going? So anybody who was seen in your ED and discharged or transferred to any of these facilities here under the inclusion should be a part of this population. So if they are transferred to some facility, that's a hospice. Any kind of healthcare facility, that's a hospice. If they're going to another acute care facility, okay, Let me say the numbers here. We thought initially that they would be helpful because they are the numbers. This corresponds to the discharge code, discharge status from the CMS manuals. And I don't know that these numbers have been helpful, so we might be removing those, but the terminology is what you really need to look for. So if they're going to another acute care facility, and that would include their emergency department, maybe you don't know if they're going to be admitted to that other acute care facility, you're just maybe transferring them to their emergency department, that's fine. They're going to another acute care facility. If you would be sending them to another critical access hospital, I don't know how much that happens in your state, maybe it doesn't, but there are some, in some real remote places where you might be transferring to another critical access hospital because maybe that one's got a little bit bigger or has more services than yours does. So transferring to any other acute care facility, general, a PPS one, you know, a larger tertiary one, a critical access hospital one, or if they were being sent to an acute care facility, a cancer hospital or a children's hospital, or a VA hospital, okay? All of those fit under acute care facility, so those people are included. I don't think we usually have a lot of issues around that, but this is our big issue. Other healthcare facilities. So anybody who was discharged or transferred from your ED to an extended care or an immediate care facility, if they were sent to a long-term acute care hospital, any long-term care facility, if they were sent to a nursing home, a skilled nursing home, any nursing home, okay? If it's a VA nursing home, if they're going to a psych hospital or a psych unit of a hospital, a rehab facility or a rehab unit on a hospital. If they're going to a swing bed, okay, a transitional care unit, all of these people, all of these facilities fit under the heading of other healthcare facility, and they should be included in the population. It does not matter if people live there before they came to the ED. So if you've got someone who lives in a nursing home and goes to the ED and then goes back to the nursing home, for these purposes of abstraction, that is not a discharge or transfer to home. They're going to a nursing facility, a skilled nursing facility, a nursing home, sorry, that fits under other healthcare facility, so those people need to be included. Now, it might be tricky if I don't know how you guys determine how you get your list of patients that you have to do for this abstraction. But if you're running, you know, if somebody's running a report for you or you're running a report and it's by your discharge status code, and your discharge status code of 1 is home, okay, and you consider at your facility, and I think that's sometimes what happens for billing, that if patients, if they live in a nursing home and they go back to the nursing home, that's a discharge status of home, then you've got to do something. Either you have to try to get that report run differently, or you have to get that report and include your home and then pull out the nursing home people. And I'm sorry, I can't, you know, tell you how to run your report or how to do this. I can just tell you, nursing home patients should be included. That's not considered a discharge or transfer to home. For our purposes, I'll come back to this note later, but for home, for our purposes, for abstraction, that would be discharged or transferred to any facility called assisted living, court law enforcement. So if they were transferred to jail or prison, any kind of detention, if the documentation said they were going to board and care, or a group home, or if it was a homeless shelter, that's considered home for abstraction. If they went home, but they were having home health services, that's still considered home. Any home, but they're getting some kind of outpatient services, that's still considered home. And so these would not be included. Okay, so these would be the patients you do not have to do, and then these are the ones that you should be including. Does anybody have any questions before around that? And maybe all of you guys have been doing that, and that's really great. But I've just been hearing lately that people, for whatever reason, have not been including those. So I'm really, I'm glad if I'm emphasizing this to you and you already know it. I'm sorry that I don't want to be wasting your time, but I want to make sure people understand, because it is not correct. And the other thing is, and I don't know that you're doing this, but I'm finding out that this is kind of happening too. There's no picking and choosing. When you do a measure, this is the population. There's no like, you know, well, we're just going to do acute cares. No, that's not the population for the measure. You're not doing it correctly. You should not be doing it then. When you're doing a measure, you follow the instructions, and this is the population. Do we have any questions around that? Okay, I'm gonna think no. We have a note here. At this time, if you've got an ED patient and they were put in observation, and then they were transferred or discharged to any of these facilities up here, they should be included. Now, we're aware that there, people have had a lot of questions about this because, you know, sometimes they could be in observation for quite some time, whatever. So we are making a change around this one. But for now, observation patients should be included. If they're seen in the ED and are in observation and then they get admitted to your facility, they would not be included. But anybody who's in observation and then gets transferred to one of these facilities should not be included. Oh, and while I'm thinking about it, let me say that this does not include for critical access hospitals. I think sometimes even for people who are admitted to your facility, maybe you do discharge them and then admit them. It's kind of maybe a billing thing or whatever. But anybody who's seen in your ED and then is admitted to your facility would not be included. We're talking about facilities other than yours, acute care facility, okay? So you wouldn't want to include patients that are seen in your ED and then you admit to your acute care facility. One more time, any questions, or I'll just go on? Okay. Please let me know if you have any questions, or if you think that you're hearing this for the first time or something. You know, it's very helpful to know. I think that we're maybe confusing people a little bit. I want to talk about the sample size here. And again, maybe you guys aren't, but just to let you know. The sample size, the reason this is here is because I don't know the size of your, you know, how many people you see in your ED. Some people, you know, depending upon your location and your, you know, some people see quite a few, but we say a minimum of 45. So what this is all saying here is if you see less than 45, you do all of them for the quarter, okay? If you see more than 45, you can do as many more as you want, okay? You could do all of them if you wanted, or you could choose a sample size that's greater than 45, but a minimum of 45 if you see more than that. Because I think maybe this hasn't been the best little graphic. We tried to do a sampling graphic like it was in the CMS manual. What we're trying to say here is if you see less than 45 cases for a quarter, you would use them all. If you see between 45 and infinity number, I don't quite know how we got to the 900, but if you see between more than 45 cases, the minimum to do is 45 for the quarter or 15 a month, but you can certainly do more. The most important thing is sample randomly. Okay, the idea here is that you really want to get all of the different kind of shifts from your ED, you know, because maybe you've got, you know, a nurse and a physician that are great documenters, and then maybe you've got some that, you know, maybe aren't so good. You want to make sure that you are hitting all of the different staff in that ED. Don't just take a day and I'm going to do everybody on that day. That's not a random sample. And you're not really getting a clear picture of what's happening in the ED there. So random sample. We don't really tell you how to do random, but just, you know, please don't pick a day. So again, minimum of 45, but if you have more than that, you can do as many as you want. You know, again, I've got some people in Minnesota who do them all. Some people have decided, oh, I'm gonna do like, you know, 60, I'll do 20 and whatever, you know, however you want, but the minimum is 45. Measure calculation, this just kind of talks about how you've got all the different data elements, but it's really when you come down to the measure, if they haven't met them all, you really haven't met the purpose of the measure. You know, it isn't good if some of the data elements get sent and others don't, but when it's broken down by data element, then you can kind of see if maybe there's a certain area that you're falling down on. You know, like maybe some of the demographic stuff isn't ever being sent, or you're having some questions around, or, you know, there's some questions about the test results or whatever being sent. So when you break it down by that's a good way to use it for quality improvement, to see if there's certain areas. But the measure itself is either, you know, everything was sent or it wasn't. And this is how we kind of try to explain what we mean by sent. When we go through the different pages, we're always saying its documentation must indicate that the data elements were sent. So what does that kind of mean? So if you have a shared electronic medical record, documentation must indicate that the data elements have been entered into the system and were available to that receiving facility prior to transfer for those administrative measures. That's the physician documentation and the hospital-to-hospital documentation, or facility-to-facility, excuse me, or within 60 minutes discharge for all the other measures. So again, it isn't enough just to say, oh, we have a shared record, we have a shared EHR. Because what we found out is it doesn't always mean that the minute someone is entering data in your facility, that is automatically being able to be seen in the other facility. We've heard some different things that some people will, I might not use the right phrase, but like they will update their system maybe a certain time of day or once a day or whatever, and it's not always meaning that they can see what you've entered right away, even though you have a shared medical record. So that is really something that you need to check out. It isn't enough just to know that you have a shared. It's, is this information available within these time frames? If you don't have a shared record, okay, when we use the word sent, what we mean is that medical record documentation indicates that that information either went with the patient, so, you know, your ED, you know, made copies and gave that to the patient to go with them, or they faxed it. They could have a phone conversation about it. Or again, if it's via some kind of electronic, it has to be done within 60 minutes of the patient's discharge. Let me talk a little bit more about this. When we say documentation must indicate that the data elements, you know, when we use that phrase, we need to know, if I went to your hospital tomorrow and started to do these EDTC records, I don't know what your process is. I don't need to know what your process is. I need to be able to see documentation in your ED record that the data elements that we're looking for were sent in one of these ways to the receiving facility, okay? So it is not enough to say ED transfer record sent, okay? What's in your ED transfer record? I wouldn't know that. So if all I saw was ED transfer record sent, and I don't have any form there that says, hey, this is what the ED transfer is, and this and this and this and this was sent, I would have to check that as a no, because I don't know what was sent. I've seen transfer documentation sent. Well, unless I have a sheet, unless there's a sheet in your ED record that says this is the transfer record and everything on it was sent, I don't know what was sent, okay? We need to know that the data elements that we're looking for were sent. So you have to have terminology that lets the person know that's doing the abstraction that the specific data elements were sent. Now, if you said ED record sent, okay, we have decided that that would mean we are taking that to mean your ED record, the entire record was sent. And so in that case, what you would want to make sure is, the certain data elements that we were looking for, that they were documented in there. But as long as they were, and there was, on your transfer form or whatever, it says ED record sent, that would be acceptable. We would take that to mean the whole record was sent. Now, I've seen where some documentation where it says pertinent ED record sent. Have no idea what's pertinent to me, might not be what's pertinent to you. That's not telling me enough. That's a no for me. Don't know what that is. I'm trying to think of some of the things that I have seen lately when I was doing like the pilot for this. Anytime you say that only a specific document was sent, okay, unless there's something that says that document or you've got a copy of that document, if you say transfer form sent, and then your record has a document that says transfer form, and it's got that, those data elements on it, or it's indication, it's indicating on there that these pages in the record went, then I could use that. I would be able to go back and see, okay, yep, that page has that on, that has that on it. I could say yes. But you can't make broad statements of transfer packet, transfer form, anything like that, unless we know by the documentation that the data elements were on there. Same thing with now we say sent, it can be a phone. Okay, if you're indicating that transfer information was discussed with so-and-so, if you only say transfer information, I don't know what that is. Okay, if this communication is a phone call, there's got to be something there that says this was discussed, this was discussed. All of those data elements that we were looking for have to be there to be able to say yes. So this is what we're talking about when we're looking for documentation. We've got to see in the record that the data elements were sent. It can be as simple as, and I don't mean to say simple in that, I know it's not so easy to make a new form or get a form, to add to your record or whatever. But, using your EMTALA form, that you can use that. You don't have to use it. There's no EMTALA form for nursing home patients, so, that wouldn't be a help there. But if you've got an EMTALA form and it's got, it has some checkoff boxes, or you can add checkoff boxes that talked about what part of the record was sent, that's fine. If on your discharge form, if you can add something, or you've got something on there that says, ED record sent, or lab sent, physician note sent, the different areas that we're looking for, and those are checked off, that's fine. But it has to be clearly stated that the data elements that we're looking for were sent. Excuse me. Any questions around that? And the reason I'm really hammering this home is this is where I found people there's errors. Everybody who did our pilot for EDC didn't have any problems with the new measure. Anything with the new stuff was fine. So please don't be concerned or be worried when you're hearing that there's going to be some new, that these are changing. The changes you're going to like, they're really for the better. But what I found with that, it's not the change that people are having trouble with. It's this stuff about the population and the sampling and the documentation that's acceptable. So excuse me for maybe harping a bit on that, but that's where I found that there still are errors. So any questions on any of that? You guys can hear me, right?
Yes.
Okay. Laura, you maybe just have really trained them really good, or everybody reads my MBQuip monthlies where I talk about this over and over again. So that's really good, you guys. I'm not going to talk about these submeasures. Again, these are where the data elements are, you know, they belong to like these specific submeasures. Like this first one is about the administrative communication. So that's where the two measures, the communications measures fall into. I think as far as abstraction goes, these aren't, you can read these on your own. I don't think there's any questions around that. So now we're getting to the specific data elements. This one, healthcare facility to healthcare facility, okay? I think sometimes people maybe give themselves a no when you don't, it doesn't need to be that much information here. What we're just saying, did someone from your facility contact the other facility? Was there some communication? Okay. For the most part, it is kind of asking, do you have services? Will you accept this patient? You know, is there a bed? Is there services available? There's nothing here that says, oh, excuse me, nothing says that it has to be report, okay? I mean, it certainly can be that would fit this, but it doesn't have to be, because we know that a lot of times you're taking care of the patient, or your nurse is taking care of the patient, and so they might not have time to do a report to the other facility until maybe after that patient leaves. But that's not what we want here. We want communication before that patient left, that this place will, wherever they're going, will accept that patient. Okay, and the suggested source documents, the reason why, if you're wondering, why do we have this set up this way? For any of you who do the abstraction, the inpatient or outpatient, this is how the CMS manuals are set up. They have their data element, and then it's like, okay, these are the values, here are some notes, these are the sources. That's why this manual was set up this way, to kind of, you know, our thought was that people who do the inpatient or outpatient abstraction might be the ones doing this, and they would be familiar with a manual set up this way. So that's why it's looking like this. Again, just stop me or Laura, let me know if there's any questions. Physician to physician, it's that the physician at your facility, or if it's the advanced practice nurse or the physician's assistant, that they communicated with a physician, APN, or PA at the other facility to have a discussion about accepting this patient, or, you know, the care of this patient. And a lot of times I think you do get this from transfer forms, you know, pretty standard transfer forms will have this information, like who the physician was that was talked to at the other facility, or maybe even an EMTALA form. And again, if I didn't mention this before, you can look, this whole ED record is a source document. So you don't have to have one page that's got all of this on it. If you've got a few things that are on this EMTALA form, hey, great. You know, maybe the reason for transfer plan of care is on there, and the physician documentation, physician to physician is on here, and maybe the healthcare, that's great. But if you have to look at maybe some transfer summary or some other form that will say, yeah, the labs were sent, or the physician note was sent, that's okay. It isn't like this has to all be on one specific document. Your whole ED department record is the source for this. Okay, so that's what we're looking for in that one. Patient name, you know, there's really not much to say about that. It's patient name. The only thing is that there is an NA for this one, and that would be if the patient was, you know, if they had a head injury, if they, you know, had any kind of, you know, they had a stroke, if they were neurologically altered and couldn't give you their name, okay, that's an NA. If for some reason the patient just wouldn't give you it, that's an NA. Sorry for the scrolling, if that bothers anybody. Address, same thing. Age, same thing. Okay, date of birth is okay. If your record doesn't have that they were 20, but it's got their birth date, you know, that's acceptable. Gender, okay, yes if no, or if it's not available. Patient contact, same thing, yes or no, or if it isn't available, excuse me, NA. Insurance, same thing. Vital signs, okay, we don't say like it has to be the last one, or it has to be, you know, you have to have so many or whatever. I mean, this isn't really about, I think you guys can maybe use this information to kind of help with like your quality or whatever, but you know, we're not saying you have to have these vitals taken within so much, or, you know, you should make sure you send the last one that was done within so much time. This is just really indicating, was that information sent to the receiving facility? And respiratory rate, the rest of these vitals, blood pressure. The only not applicable there would be if the patient is less than 3 years of age or less, then it's not, you don't have to, we don't require that there was one. Or if there was some, if you couldn't assess the patients because maybe they were combative or there was a problem and you couldn't get it for some, you know, physical reason with the patient, then it could be an NA. Oxygen saturation, same thing, consider that as part of the vitals. And temperature, there is temperature, it seems to be that almost a temperature is usually taken now. I think when maybe back when this last version of the manual was put together, it wasn't always taken like it is now. So it's, for this abstraction, it is only required for patients if there's documentation of a suspected infection, hypothermia, or a heat disorder. So you wouldn't have to say a no if there wasn't a temperature. The person came in like with maybe they just sprained their ankle. Don't give yourself a no if it isn't there, because it's not one of these reasons. But if it's there, I would just check a yes. But it's okay to do NA as well. NAs are considered yeses if you're worried about that in the scheme of how things are counted. But these are the only ones that definitely there should be a temperature set, or excuse me, there should be a temperature and that should be sent for these conditions. Neurological assessment. This one, I'll be the first to admit, it's not too bad. Again, this is only required on patients with documentation of altered consciousness, if they had a head or a brain injury, if they were having a seizure or post-seizure, trauma, stroke, or TIA. These are the ones that a neuro assessment should be documented and sent. So again, if a person came in for like just a sprained ankle, well, that's kind of a trauma. Okay, that probably wasn't, well, I guess that would be considered trauma. I mean, maybe. Maybe if they came in with a, well, I wouldn't want to say anything. Trauma fits almost everything, okay? So that one's kind of hard to say. This is a question that we're going to make more clear, I think, in the next manual. But I think for the most part, a lot of times there is like a neuro assessment. But the only one that we're requiring it for is for like these conditions. I don't know if anybody has trouble with that. People don't ask me a lot of questions about that one, so I'm thinking that people are being okay with that one. Meds administered in the ED. Okay, these are medications that were given while they were in your ED. Okay, if there were no medications given right now, there needs to be documentation that states there were no meds given to answer yes. Okay, if there were no meds given, but it doesn't say that anywhere, okay, it doesn't say that anywhere that none were given, right now that's a no. Allergies or reactions. So if they're using the term reactions and they don't mention allergies, that's okay. Or allergies are okay. So either of these words are acceptable. So you want to see that there was documentation about that information and it was sent to the receiving facility. If it says allergies are unknown, that's okay to select yes. That we take that to mean that that was, someone tried to make an assessment of that, or the person doesn't believe they have any known allergies. That's a yes. So any kind of allergies or reactions, food or medication or anything else. Home medications, what we're referring to are the medications that the patient came into your facility on. Okay, so I think that history word, I don't know, that's caused a few people to have some questions about that. What I don't want to just see is that somebody reviewed the med list from the last time the patient was in, because how do we know that since the last time they were in your facility, they haven't had something added or changed or whatever? So we want a current medication list, the patient's current medication history, or I don't know that history word, current medication list. Maybe that's a better term to use. So if it says patient is not on any home medications, that would be a yes. Thing about this one, history and physical ED provider note, doesn't have to be a history and physical. Because I think a lot of times you don't do histories and physicals per se when the person's in the ED. So we're talking about the provider note, be it the physician or the advanced practice nurse or the physician's assistant, their note, okay? It has to minimally include a history of the current ED episode. Why are they there? A focused physical exam around, why they're there, what's the issue, and any relevant chronic conditions. And you would exclude chronic conditions if that patient was neurologically altered, if they couldn't tell you that they had asthma or they were a diabetic, okay? Otherwise, that's relevant chronic conditions. Needs to be sent. Reason for transfer plan of care, you'll definitely, this is a big one where you can get it off like the EMTALA form for your maybe acute care transfers, but why is this person being transferred? Okay, why are they sending them to another acute care facility? Or if they're going back to the nursing home, what's the plan of care for for them once they go back there? That's what we're looking for here. Nursing notes, we really don't define them what they should be, but the nursing documentation, usually the nurses stuff, before the physician is seeing them, maybe they've collected some of the history and physical I shouldn't say H&P, some of why the patient's there, or their medication history or whatever. Sensory status, oops, sorry. It used to be called impairments, but really what we're looking for here, what you would find most often is that there was an assessment for one of these things. A mental status, speech, hearing, vision, sensation impairment, at least one of those. So if in the provider note it says patient was alert and oriented, that's okay for this. That would be a yes. Talks about that they were oriented. Okay, even in a nursing note, what they're saying here is that if there's an assessment that they have a hearing aid or they wear eyeglasses, that's an assessment and that would be acceptable. I think a lot of times people are probably harder on themselves than maybe what they have to be for this one. But this is another one that's undergoing a change, and we've made it a lot more easier to, we've defined better what's being wanted for this one. I think some of the rest of these, I want to make sure I leave some time for questions, but were they put on a catheter or any IV? Okay, if they were, that information there should be documentation that that information went to the receiving facility. And it's an NA if no catheters were placed. Same things with immobilizations. I mean, if you put the person in a cast or a brace or a backboard, any of these things, you know, that information should obviously be sent. Respiratory support, you know, if you gave the person oxygen, if they were on oxygen, if they were on a vent support, or any of these things were done, there should be documentation on that, and that should be sent. Oral restrictions, this is kind of a weird one, but I mean, not so much so if the person is maybe going for further surgery, but if it says anything about that they were placed, you know, nothing by mouth, NPO or clear liquids, or if it talked about any kind of a diet, that information should be sent. And if there's nothing about that, then no restrictions were placed. That could be an NA. Test procedures performed, so any labs, any x-rays, any of that information, if they were performed, that information should be sent. So this is the one that's just kind of saying, hey, these were performed, that should be sent. This one is talking about the results. Okay. For any labs, for any x-rays, those should be sent. Okay. Or a lot of times you're not going to have that information within this time frame. Then there needs to be some documentation on how that facility is going to get these results when they're done. Okay, if there's no plan to communicate, if there's nothing, if you just did a culture and there's nothing that says, you know, we'll call blah, blah, blah facility when, you know, we get the culture back or anything like that, then that would be a no. And those are the data elements. If you aren't aware of this manual and the first time you're looking at it, there is a paper tool for some people who don't like to maybe enter right into like an online tool, but there's the paper tool with all of the questions. And one thing I forgot to mention, you guys, about the physician-to-physician communication. So let me get back there. Physician-to-physician communication, it's only, there only needs to be physician-to-physician communication if the transfer is to an acute care facility. So if you've got a transfer to a non-acute care healthcare facility, then you would put an NA. Because we do not expect that if your patient's going transfer to the nursing home or discharged to the nursing home, that there's going to be able to be physician communication at that nursing home, or a skilled nursing facility, or you know, any of those listed under other healthcare facilities. There might be, and that would, you know, that's great. I mean, but if there isn't, this is only applicable to being transferred to another acute care facility. So sorry, I think I kind of took up a lot of your time there, but anybody have any questions around anything with these?
Hi, Robin. We had a question come in, and it was from Jennifer and Shattuck. Is anyone willing to share their forms that they use? Do you still have some of the examples on the website too?
Yeah, I think we do. But you know what? In case I've got some other ones or whatever, I can send them to Laura, and then. Okay.
And I will get those out to everyone. Are there any other questions? Robin, one thing that I was taking notes of, and I think I've possibly been telling people wrong, the sample size. I think in the earlier specification guide, I might have interpreted it as, you know, 45 is the max, and if you have beyond that, to sample out to equal 45, but it can be any number you want, right?
Yes, and
at least 45.
And you're not the only one. So, and I think maybe it's because I don't think this little grid here is like helpful, because when you look at it, it looks like no matter how many patients you have, you only do 45. But no, you can do as many more, as many as you would like. Over, you know, once you get over, you know, as long as 45 or more.
Okay.
I'm sorry, I'm trying to think of a better way to say that. Yes, you can choose to use a larger sample size than is required.
Okay. Well, I am updating our submission form then to allow for that. So for those who are on the call who have done the submission and the past, it's In the past, it's been a drop-down menu option to select your number. Now it's just going to be a type-in option. So you just type in the exact numbers. It should actually scroll faster because you can just tab through it then and just use your keypad. So just to note, when we do open this again on October 1st.
And I think, you know, some people, granted, you know, 45 was kind of, the thought was by doing that many, you can tell if people, you know, are people doing this correctly or not doing this correctly, or are we, you know, are we following, is this stuff getting sent or not? But we you know, we do have some people who, hey, we really want to check on all of our cases. We don't want to let, you know, maybe one have slipped by or whatever. So you certainly can do as many as you want.
Okay. I'll include that when we open this up again too.
And we hopefully in the new manual that comes out, we've tried to make this a little clearer. We've kind of got rid of this grid because we don't think it's helpful. Hey, and if anybody has any suggestions, if there is something that they think isn't clear, and maybe it's just clear because I was talking about it, if you have any thoughts, you know, we can't change, the measures are going to be what they are. There's no change in that, and there's no change in the population. But if you think something isn't maybe clear the way it's worded, you know, you can shoot me an email or shoot it to Laura and she'll get it to me. Because we do have a little bit of time right now that we're working on trying to make the manual, you know, clear and easy to understand. But again, you know, no measures are going to change and the population isn't changing. So sorry, can't do anything about that. I mean, the actual measures, they're going to be what they are now. But if there's something around the manual about the instructions, you know, just let me know. We might be able to look at that.
All right. Does anyone else have any other questions that they'd like to ask Robin?
Oh, and let me put in one last thing. I'm sorry. Laura kind of plugged it, the abstraction for accuracy. But let me say this too, because I've kind of found out some people had thought, well, you know, I don't want to do that. We're not doing this because we have, you know, most of our fields are downloaded from our EHR. So, you know, whether you use the CART tool or whether you use a vendor or even if your fields, some of them are downloaded from your EHR, you know, into your CART tool or however you do it, you know, all of that still really needs to be checked for accuracy. I was doing a hospital last week and, you know, and again, I will say that, you know, we really have to do this paper. So it does require you to make a copy of, you know, that ED visit or that encounter, you know, that you've abstracted. I need to see that and I need to see how you've abstracted. But I mean, I was doing a chart a couple weeks ago and there were 4 different arrival times. Okay, well, now, you know, you only arrive at the hospital once, but there were 4 different times where it said arrival time. So, you know, the first thing that somebody has to do there is sit down and you know, I mean, and again, it's easy for me to say this, but a person does not arrive at 4 different times. So who's documenting this in the different spots in the record? And what time are you taking for abstraction? We want the time in abstraction. The time is, you know, oh, and I'm kind of deviating from EDTC, but sorry, I just want to plug that abstraction for accuracy. But, you know, you want, what time, what's the accurate time? What time did they really come of these 4 times? You know, I was doing 2 abstractors and all 3 of us put a different time. So, you know, that's the thing that's coming out of some of these abstraction for accuracies as well. It's like, you know, this stuff might be downloaded from your EHR, but is that being done correctly? Are they really pulling what this data element, what this measure is asking for? So don't think that just because maybe you're doing it that way, that it doesn't need, you know, that it doesn't need to be checked for accuracy or whatever. So just throwing that out there. Sorry.
No, that's great. Just real quick, it's 2 o'clock. Does anyone else have a question you'd like to pose? Or again, if you get off the call and have any questions at all, please let me know. Our plans to get this recorded, get this on YouTube and make it available so we can come back to it later.